guys. Thank you, Laura, for taking part. As I said earlier, I'm Emily, and I'm going to be leading this debrief, a chance for us to all share our learning. And this is Sam, who I know you've met, and in this debrief, Sam is going to be back to himself, so a member of the faculty, and not playing sort of the doctor like he was in there. So thank you, Laura. I'm initially going to start with talking about feelings, and then we're going to go on to talk about the nitty-gritty and the things that we always like to talk about with the simulation. But first of all, share with me your feelings. So how does it feel having come out of there looking after Colin?
I feel okay. I felt a bit stressed, and I found it a little bit stressful, but I feel okay to finish that.
Yeah, great. Okay, thanks for sharing that with us. I think we would all feel stressed if we were presented with a patient like Colin, who was kind of acutely unwell and had deteriorated. So I think that is a normal feeling. But thank you for sharing that with us. Was there any part of this simulation that made you particularly feel stressed, or was it kind of the whole thing?
I think, it's stressful when patients are deteriorating. I actually found the biggest stress was the fact that I needed a review from the medical team, and I didn't feel that my concerns were being listened to, and I felt quite stressed after having that conversation and being like, oh, I'm not sure what to do now, because I've done what I felt I could do, but I'm still worried about this patient, so that felt quite stressful.
Yeah, absolutely. And we're going to go on to talk about that, but that was kind of one of our main learning objectives of today. And again, I think I can definitely relate to experiences that I've been in, and that is stressful because, the patient is unwell and you want them to be seen. So we will talk about that. Thank you for sharing. I wondered, Laura, if you would be able to sort of summarise, just in a couple of sentences for us, who the patient was and what happened in that scenario.
Yeah, so it was a gentleman called Colin who'd been admitted to hospital, and the NA had been a bit worried and asked me to review him, and I did an AT assessment, and I was quite concerned about him at the end of that assessment.
Yeah, great, thank you. So exactly that, and as I mentioned, sort of one of our main learning objectives was about sort of escalation and challenging that when sometimes it might be difficult. So exactly that, Colin was who you understood him to be. He deteriorated in that scenario, and actually he was showing early signs of sepsis, and sort of with it reflected in his new score of 5. And we wanted you to escalate, as you did to Sam, and kind of Sam was always, he'd been sort of primed to be task overloaded and not able to prioritise, and we wanted you to kind of challenge that, and because it was important that Colin needed to be seen and have that review. So I noticed that you accurately calculated the P's of 5, and it was clear to me from your really thorough AT assessment that you were worried, and you vocalised that you were worried about the patient. What concerned me was that during the duration of the scenario, the patient still wasn't seen, and it was clear that that was what you wanted, but you weren't able to kind of get Sam to come and see this patient, and he had said like he would be an hour or more because he had all of these other things to do. I'm interested to know sort of your thoughts, and I know you mentioned a little bit about this in your feelings, but tell us a little bit more about sort of your thoughts and feelings about, and what happened with that.
Yeah, I guess I was worried that Colin could be septic, and I know that we have this golden hour where we need to do all these things so that we try and prevent the patient from becoming more unwell. So I knew that actually the things I might need if Colin is septic are things like antibiotics and fluid, and I need the patient properly reviewed, which is why I definitely wanted to, and I did escalate that. I guess I found it hard because that wasn't the response that I was getting. So actually I was told that the doctor wouldn't be able to come until after an hour, and that was worrying me. I don't know, maybe I could have been a bit more sort of pushy, or like actually, or not pushy, but just really reiterated why I was concerned a bit more. I don't know.
Okay, yeah, thanks for sharing that with us. So yeah, it's really great that you shared with us that your concerns, and it's now clear that you accurately identified as Colin being potentially septic, and that urgency was obviously something that you felt, but it just sort of wasn't able to get that to happen. And that was because, kind of, as I said, we've sort of primed Sam to be, have lots of things to do, and that's quite realistic, isn't it? I can definitely think of experiences myself where, people are easily sort of task overloaded, and it's difficult sometimes to prioritise, and you kind of need that key information, don't you? So I heard you say, Laura, that you were a couple of times that you were worried about the patient, and that Sam said, do you want me to come and see them now? And you said yes, if that's okay. And obviously he had lots of other things to do. And then you asked if he could come a bit earlier because you were worried. But I didn't hear you say at all the word septic at all in that scenario. And as we've kind of explored, that is what you were thinking. And I wondered if you were aware of that, and kind of what your thoughts were.
Yeah, I guess you're right. I didn't say that, and maybe that would have been helpful to just acknowledge that, so that we're both on the same page. I think it was difficult because I know that the medical team have a lot on, and when they're sort of saying to me, I've got this, this and this, I'm thinking, oh, okay, that sounds important too, but I am really worried about this patient, so I find that sometimes a little bit difficult to, I guess, maybe challenge that and say, actually, I think this is more important than what you're describing to me, but I think that's always a bit difficult.
Yeah, and it sounds like, if I'm hearing you right, you're saying it's sort of that lack of confidence, if you like, in sort of, exploring and telling them that actually, no, my patient is a priority, and this is what you need to do first. I wondered, Sam, I can think of a couple, but if you have got any sort of tips or tools that you've used before, if you've ever been in the situation of and to be on the other end of this kind of escalation, what might have helped sort of that you prioritise and you hear Laura's concern? Is there any tools that you've used before that you could share with the group?
Sure. So thank you, Laura, for engaging the scenario. But I think that you briefly touched on this, sort of declaring the emergency in saying the word sepsis. I think that can be really important in sort of refocusing people's minds, especially something that, like sepsis, which is a buzzword, that can then really make you think, oh, well, actually, do I really need to go and do all of these other things that are on my plate at the minute? And in terms of challenging somebody, have you heard of a 2-challenge rule?
No.
So I think that's something that Emily did want to cover.
Yeah, exactly. So thanks, Sam, for bringing that up. So 2-challenge rule, essentially, you very much did definitely half of this. So you're kind of challenging. So you said, Sam, I'm really worried about this patient, and he was telling you, I'm going to take this long, and then you said, oh, I wondered if you could come a bit sooner. I'm really worried about this patient. But when you think of the 2-challenge rule, it's with that second time, sort of justifying it, so giving it a reason. Okay. So it's really clear that you had the knowledge and you absolutely knew what was going on with this patient, but as we've identified, that sort of wasn't, you didn't share that mental model, and that often happens, and this is why picking these sort of things up in SIM is often sort of just makes us aware of it. But saying, for the second time, oh no, Sam, I'm really worried about this patient, I think they are septic, and these are the reasons why. Like Sam said, that kind of buzzword, and giving that sort of a reason just adds that sort of emphasis. And it can, you know, confidence, it can be a challenge, but you know, you have got lots of things that sort of back you up, if you like. So I observed you have a little look at the escalation, and what did you, I've got it here, but what sort of was the time frame that you wanted this patient to be seen in?
So sort of, I think it's 30 minutes that they needed to be seen by for scoring above a 5. So that's what was pushing me to want them earlier.
Yeah, which is why you quite rightfully weren't very impressed when he was going to be sort of over an hour. So yeah, kind of saying, you know, yeah, I'm worried about this patient. I'm worried because I think they're septic, and actually I need you to come and see them within the next 30 minutes. The 2 challenge rule is kind of the one that I often think of first, but I don't know if you've kind of ever sort of heard of another term called CUS, if that's something.
No.
So again, it's another tool sort of around challenging decisions and giving you the confidence to sort of speak up, and it stands for concern, unsure, safety, stop. So it's kind of like a four-step one, but you know, Sam, I'm concerned, and then when he says he's going to be, you know, over an hour, it's sort of actually, no, I'm unsure that that's not appropriate, and then when he's still not sort of hearing you, actually for the patient's safety, I think that you need to come back within the next 30 minutes, and then actually stop, Sam, like, you're obviously not hearing me right, you know, this patient is really unwell, and it's kind of that actually, no, this is a priority. And it's fine to, if you have the confidence to do that, even if that's not what's happening with the patient and that's not right, it often just allows that opportunity for discussion, doesn't it, and sort of to hear others' thoughts of what's going on in their minds. Anything else you wanted to sort of ask Laura about, any questions or anything you wanted to ask about the...
I guess if I try all those things and it still didn't work, like, is it okay to sort of go up the rank and call someone else, or like, you know, I've always felt it's all right to, you know, you can call the consultant, but like, is that justifiable at that point then?
Absolutely, yeah, and that's a really good point, and thank you for bringing that up. And I'm sure you'd agree, Sam, but yeah, absolutely. If you have concerns, you're not being heard, then you've always got sort of your nurse in charge, who's always sort of a really, you know, good second person to sort of share opinions and thoughts with. And then absolutely, if this patient needs to be seen, and for whatever reason someone isn't hearing you, then absolutely. And would you agree, Sam, that
yeah, definitely.
escalating further?
Definitely. It's the same with, you know, to put it in the context of the bleeping system. If you can't get hold of the SHO, then there's always a registrar, and ultimately there is always a consultant on call who is responsible for the patient, and it is their patient, so they should take an active role in the care. So although it can seem intimidating, ultimately you're just advocating for the patient. You've got the patient's safety in mind. So yeah, definitely. If you disagree with the decision, you should feel empowered to go over somebody's head.
At the end of the day, you know, Sam was too overloaded to hear you, but he would have been deeply upset to then come back and have found that actually, you know, you were right, this patient was really unwell, and things are going to be sort of a lot further down the line and a lot worse then, aren't they? Great, thank you. Any other questions, Laura?
No, I think that's
Okay, fab. Thank you. So I guess just to sort of summarise our take-home messages, which we've sort of shared our learning points today, the ones being sort of having, you know, using the tools that are around in terms of the escalation pathway and the news to give you kind of guidance as to who and when to escalate to, and that there can be challenges with that, and so we've sort of explored the tools that can give us a little bit of confidence and guidance in challenging you know, those people, and maybe they might be more senior or they may not always, but using the tools such as the 2 challenge rule and also the CUS framework to help us. Great, thank you.